Welcome to the Deep Dive, everybody. Today we're diving into a topic that's pretty much guaranteed to show up on your MCCQE exam, obesity. But first, let me quickly introduce myself and my colleague. I'm Harvey.
And I'm Donna.
And we've both spent years reviewing the MCCQE. And we're here to kind of break down the most important information and make it, easy to understand.
We're using top-notch resources like stat pearls, to make sure everything we talk about is accurate and relevant, of course. Our goal is to help you, the listener, feel prepared and confident when you sit down to write that exam.
Exactly. And just a quick reminder, this deep dive is meant to be a companion to your studying, not a replacement for it. We're not giving medical advice here.
Always consult your professors, your textbooks, and, of course, qualified healthcare providers for personalized guidance.
Now, with that out of the way, let's get to the heart of the matter. Obesity is, it's a huge public health issue.
It really is.
Did you know that like a third of adults in North America are obese?
And projections suggest that by 2030, 1 in 2 Americans could be obese.
Yeah, those are some startling statistics. It really highlights why this topic is so important for future physicians like yourself. So, Donna, let's break this down. How exactly do we define obesity in the medical world?
Well, the most common way to define obesity is using the body mass index, or BMI, as it's more commonly known. And it's calculated by dividing a person's weight in kilograms by the square of their height in meters.
Okay.
It's a pretty simple tool, but, it's not perfect. It has its limitations.
Right.
For example, it doesn't differentiate between muscle mass and fat mass. So, like, a very muscular athlete, for instance, might have a high BMI and be categorized as overweight or even obese, even though they're in excellent physical condition.
That's a really great point. It's a reminder that we can't just rely on BMI alone. We need to look at the individual's overall health and their body composition. Now, once we have the BMI, we use it to categorize individuals, right? Can you walk us through those categories?
Sure. So a normal weight BMI falls between 18.5 and 24.9.
Okay.
And anything below that is considered underweight. And above 24.9, we enter the overweight category, which ranges from 25 to 29.9.
Gotcha. And then 30 and above is where we hit the obese category, officially.
Exactly. And within the obese category, there are further subdivisions. Obese, extremely obese, super obese, and even super, super obese.
Wow.
It's a pretty sobering scale. That really reflects the escalating health risks associated with an increasing BMI.
Yeah, it definitely highlights the seriousness of this condition. Now, something that's always fascinated me is this idea of the metabolically healthy obese individual.
All right.
Could you shed some light on that for our listener? What does that even mean?
Absolutely. So metabolically healthy obese, or MHO, are individuals who have a high BMI, which puts them, in the obese category, but they don't exhibit the typical metabolic problems that we associate with obesity, like, for example, dyslipidemia or insulin resistance. It's almost like they defy the odds, at least initially.
Right. But what about in the long term? Do these individuals remain metabolically healthy, or does that change?
That's a crucial question, and research suggests that while some obese individuals may seem metabolically healthy in the short term, they are still at an increased risk of complications, particularly in the long run. For example, studies have shown that they face a higher risk of stroke, even if they don't have any other metabolic issues.
So it's not like a get-out-of-jail-free card.
Right.
Even if you're currently metabolically healthy, obesity still poses some pretty significant health risks down the line.
It does.
This must have important implications for how we approach treatment, right?
Absolutely. It really highlights the need for a proactive approach to obesity management. Even in those individuals who seem metabolically healthy, early intervention and lifestyle changes are crucial to, mitigating those long-term risks.
That's a key takeaway for our listeners. Now, keeping in mind that our audience is comprised of, medical students prepping for the MCCQE, let's turn our attention to some of the specific orthopedic concerns related to obesity. How does obesity affect our bones and joints?
Sure. So obesity has a significant impact on orthopedic health, and this affects both children and adults.
Okay.
From a biomechanical standpoint, the excess weight puts a lot of stress on the joints, leading to wear and tear.
So we're talking about like an increased risk of things like osteoarthritis?
Exactly.
Okay.
But it's not just the mechanical strain. Obesity is also linked to chronic inflammation, which can further damage the joints, contributing to pain, stiffness, and the breakdown of cartilage.
It's like a double whammy then.
Yes.
The source material also mentions some specific orthopedic problems that are more common in kids, obese children. Can you tell us a bit more about those?
Yeah. Two prime examples are Blount's disease and slipped capital femoral epiphysis, both of which affect the legs. Blount's disease is a growth disorder of the tibia. Basically, the inner part of the shin bone bows outwards. And it's more common in obese children because the excess weight disrupts normal growth plate activity.
And slipped capital femoral epiphysis. What exactly is happening there?
So in this condition, the ball at the top of the femur, that's called the femoral head, slips out of place at the growth plate. Again, obesity plays a role because the extra weight stresses the hip joint, making the growth plate more vulnerable.
These conditions really highlight the long-term consequences of childhood obesity. Switching gears a bit, I want to touch on something I found interesting in the source material, the set point theory. Can you explain that to our listener?
Of course. The set point theory suggests that our bodies have a predetermined weight or fat mass range and that they work hard to maintain. Think of it like a thermostat, but for your weight.
So if someone tries to lose weight, their body actually fights back to return to that set point.
Exactly. It can make long-term weight management a real challenge. But here's the interesting thing. The set point isn't totally fixed. It can be influenced by a number of things.
Like what?
Well, genetics play a role, and so do hormones. We've already talked about hormones like ghrelin and leptin. But other hormones, like thyroid hormones and cortisol, can also impact metabolism and weight regulation.
So imbalances in these hormones could make weight loss harder.
Absolutely. And then there's the gut microbiome, which is, the trillions of bacteria living in our digestive tracts.
Right.
Research suggests that the composition of our gut bacteria can actually influence things like metabolism, energy storage, and even appetite.
Fascinating. So having a healthy gut microbiome could make it easier to maintain a healthy weight.
That's the current thinking, yeah. And there's ongoing research exploring the use of probiotics and prebiotics to manipulate the gut microbiome, specifically for weight management.
Interesting. This all seems to suggest that weight loss isn't as simple as calories in, calories out.
You got it. It's a complex interplay of factors: genetics, hormones, gut bacteria, lifestyle. And of course, there's the set point that our body is always trying to defend.
Definitely adds another layer of complexity to weight management. Donna, I know we've covered a lot of ground already, but I want to make sure we have time to discuss the specific complications associated with obesity. Perhaps we should pause here and continue this in part 2 of our deep dive.
That sounds good. We'll be back soon to dive deeper into those complications and what they mean for your MCCQE prep. See you then. Welcome back to the deep dive. Before the break, we were talking about the set point theory and how, our bodies have this predetermined weight range that they like to stick to.
Right, and you were explaining how certain factors can actually shift that set point.
Right.
What else can have an impact?
Well, things like major life events can play a role. Pregnancy, for example, naturally increases the set point to support, the developing baby.
That makes sense. What about menopause? A lot of women seem to gain weight during menopause, even if their lifestyle habits haven't really changed all that much.
Yeah, you're right. Hormonal shifts during menopause, they can really alter metabolism and fat distribution, often leading to a higher set point.
So it's not just about willpower or making, better choices. There's actually some real underlying biological stuff going on.
Absolutely. And certain medical conditions can also throw a wrench in the works when it comes to weight regulation.
Like what? What kind of conditions?
Well, hypothyroidism, for instance,
Okay.
Cushing's syndrome, polycystic ovary syndrome, PCOS. These can all make weight management a lot more challenging.
That's a good reminder for all of us as future physicians to always consider the possibility of, underlying medical issues when a patient's struggling with their weight.
Right. A comprehensive medical evaluation is so important. Now, I think it's also really important to talk about the broader health implications of obesity.
Right.
It's not just about the weight itself.
Right.
It's the increased risk for a whole bunch of other conditions.
Yeah, the comorbidities. And they're serious. They can affect almost every system in the body.
Exactly. We're talking cardiovascular disease, type 2 diabetes, respiratory problems, certain cancers, joint issues. I mean, the list goes on and on.
So let's break it down a bit for our listeners, starting with the cardiovascular system. What are some of the main risks there?
Well, obesity is a major risk factor for heart disease, stroke, high blood pressure, all of which are, leading causes of death.
And how does obesity actually contribute to these conditions? What's the mechanism?
Well, for one thing, it increases inflammation, it raises blood pressure, it elevates cholesterol levels, and all of this really takes a toll on the heart and the blood vessels.
So it's a cascade of negative effects. One problem just leads to another.
Exactly. And then you have the respiratory system. Obesity can make it harder to breathe, which increases the risk of things like sleep apnea, asthma, even pulmonary hypertension.
Sleep apnea, that's a particularly concerning one, right?
It is. It involves these repeated pauses in breathing during sleep,
Right.
which obviously disrupts sleep quality, leads to daytime fatigue,
Mm.
but it also puts a strain on the heart, and that increases the risk of those cardiovascular problems.
So again, it's that domino effect.
Exactly. We also can't forget about the digestive system. Obesity is linked to problems like fatty liver disease, gallstones, and even certain types of cancer.
It really does affect so many different parts of the body.
Yeah.
What about the connection between obesity and type 2 diabetes?
That's a big one. Obesity increases insulin resistance, which means the body has a harder time regulating blood sugar. And that can lead to the development of type 2 diabetes.
And of course, that in turn increases the risk of even more complications.
You got it. Another vicious cycle.
And we've talked about some of those orthopedic issues already, like osteoarthritis, Blount's disease, slipped capital femoral epiphysis.
Right. But we should also mention back pain, joint pain, even gout. All of these can be made worse by carrying extra weight.
It's a good reminder that obesity affects pretty much every part of the body. Now, given all these different health problems that are linked to obesity, what are some of the strategies for addressing it? What can we do?
Well, it's important to stress that there's no one-size-fits-all approach. Every patient's different. Treatment plans need to be tailored to the individual. But generally speaking, the cornerstones of obesity management include lifestyle modifications,
Okay.
pharmacotherapy, and in certain cases, bariatric surgery.
Okay, let's break those down a little bit, starting with lifestyle modifications.
Yeah.
What does that actually look like in practice?
Lifestyle changes are really the foundation of any weight management plan. It's about making adjustments to diet and exercise patterns to create a calorie deficit. So burning more calories than you take in.
But it's not just about willpower, though, right?
No.
It's about making lasting changes to your habits.
Exactly. And that often means working with a professional, like a registered dietitian, for example,
Okay.
or a certified personal trainer, to come up with a plan that's, tailored to your specific lifestyle.
So it's about making those gradual, manageable changes,
Yeah.
rather than trying to do a complete 180 overnight.
Precisely. Consistency is key. It's not about being perfect. It's about making healthy choices most of the time and finding ways to actually enjoy the process. Weight management shouldn't feel like punishment.
That's a great point. It should be about empowering people to make healthier choices.
Yeah.
For themselves, for their well-being.
Mm.
Now, what about pharmacotherapy? When are medications used in obesity management?
So medications are usually considered when lifestyle changes alone aren't enough, or if a patient has other health problems, comorbidities, that make weight loss more difficult.
Okay.
And there are a number of different medications available,
Right.
each with their own mechanism of action, and of course, potential side effects.
So the choice of medication really depends on the patient's individual needs and their medical history.
Absolutely. And it's important to keep in mind that medications aren't a magic bullet. They work best in combination with lifestyle changes.
Right. They're a tool to help support weight loss, not a substitute for making those, fundamental changes to your habits. And lastly, let's talk about bariatric surgery. When is that an option for patients?
So bariatric surgery is typically reserved for patients with severe obesity, those with a BMI of 40 or higher, or patients with a BMI of 35 or higher who have obesity-related health problems. It's a big decision, and it should always be made in consultation with a qualified surgeon, a bariatric surgeon.
And as we mentioned earlier, it's not a quick fix.
No.
It requires a commitment to significant lifestyle changes, both before and after surgery.
Absolutely. It's a tool to help patients lose weight and keep it off, but it's not a guarantee. Now, before we move on to specific complications, I think it's worth taking a moment to acknowledge the psychological and social impact of obesity.
Yeah, that's a really important point. It's not just about the physical health effects. Obesity can have a huge impact on mental and emotional well-being as well.
People with obesity often face stigma, discrimination, negative stereotypes. All of this can lead to, feelings of shame, guilt, low self-esteem, and even depression.
And of course, those psychological factors can make it even tougher to lose weight or stick with those healthy lifestyle changes.
It really is a complex interplay of factors. As future physicians, we need to be aware of the challenges that our patients with obesity are facing. We need to create a safe and supportive environment for them, where they feel comfortable talking about their struggles and seeking help.
It's about treating the whole person, not just the disease. I think this is a good point to pause for now. In our final segment, we'll dive into specific examples of those obesity-related complications and how they might present in a clinical setting.
We'll also discuss how this might all be tested on the MCCQE, so stay tuned.
Welcome back to the Deep Dive. We've covered a lot of ground on obesity so far, from its definition and causes to its pretty wide-ranging health implications.
And now it's time to dive into some specific complications of obesity, the kind of things you might run into on the MCCQE, and of course in your future clinical practice as well.
Okay, let's start with one that we touched on a bit earlier. Obesity hypoventilation syndrome,
Mm,
or OHS for short.
right.
It's a pretty serious breathing disorder. Can you explain what's actually going on there physiologically? Like what's happening in the body?
Sure. So basically, OHS happens when excess weight, especially around the chest and abdomen, makes it harder for the lungs to expand.
So like the weight is physically pressing on the lungs.
Yeah, that's a big part of it. But it's not just mechanical, there's also a neurological component, meaning the brain doesn't respond as well to those signals that indicate low oxygen or high carbon dioxide in the blood.
Huh. So it's both impaired mechanics and impaired signaling. What kind of impact does that have on the body?
Well, this whole combination can lead to a buildup of carbon dioxide in the blood. That's a condition known as hypercapnia.
And that could be really dangerous, right?
Absolutely. Hypercapnia can lead to all sorts of things: fatigue, shortness of breath, confusion, even heart problems.
If we're thinking about the MCCQE, what kind of signs and symptoms should we be looking for in a patient with OHS?
Well, patients with OHS, they often complain of excessive daytime sleepiness, morning headaches, and shortness of breath, even with just minimal activity.
So those are some red flags right there.
Yeah.
What about during a physical exam? What are we going to see?
Well, obviously you're going to notice the obesity, but you might also observe, some signs of respiratory distress, like rapid breathing, or using those accessory muscles to help breathe.
Okay. And to confirm the diagnosis, what kind of tests would we order?
You'd probably want to order an arterial blood gas analysis to actually measure the oxygen and carbon dioxide levels in the blood,
Okay.
and also pulmonary function tests to check lung capacity and overall lung function.
Okay, that's a good overview of OHS. Let's move on to another complication we mentioned before, non-alcoholic fatty liver disease,
Hmm.
NAFLD. It's a condition where fat builds up in the liver. How common is this, Donna?
It's getting more and more common, unfortunately, and it really goes hand in hand with the rise in obesity rates.
Yeah. Why is that? How does an NAFLD actually develop?
That's a good question. The exact mechanisms, they're still being studied, but it's definitely linked to insulin resistance, which is, a key feature of obesity.
So the body's not using insulin effectively, and that somehow leads to fat accumulating in the liver.
That's the basic idea. Insulin resistance messes up fat metabolism and encourages the liver to store fat.
What are the consequences for liver function? Can this be reversed?
So in the early stages, NFLD is often silent. Patients don't usually have any noticeable symptoms.
It's a silent threat then.
It is. But as it progresses, it can turn into something called non-alcoholic steatohepatitis, or NASH, and that involves inflammation and actual damage to the liver.
And that's when things start to get serious.
Exactly. NASH can ultimately lead to cirrhosis, liver failure,
Yeah.
and even liver cancer.
So for our medical students out there getting ready for the MCCQE, what should they know about how NAFLD presents?
Well, like I said, early on, there might not be any symptoms at all. But as it advances, patients might start to experience fatigue, abdominal pain, maybe even jaundice. That's the yellowing of the skin and eyes.
How's NAFLD diagnosed then?
Usually with blood tests to check liver function, and imaging studies, things like ultrasound or MRI to visualize the liver and see if there's any fat accumulation or signs of damage.
Okay, we've talked about two big complications now, OHS and NAFLD. But the list goes on, right?
Oh yeah, we've also got cardiovascular disease, type 2 diabetes, osteoarthritis, sleep apnea, certain types of cancer, and they're all more common in people with obesity.
And of course, we can't forget the psychological effects of obesity either. Things like depression and anxiety. It really is a complex condition with a huge ripple effect. I bet the MCCQE could ask all sorts of questions about this.
For sure. They might ask about the underlying mechanisms of these conditions, how obesity contributes to them, the key signs and symptoms to watch out for.
Or they might give you a case scenario and ask you to come up with a diagnosis. or a treatment plan, or explain the reasoning behind certain tests or therapies.
Being able to link the science with the clinical presentation, that's crucial for doing well on the MCCQE. And more importantly, for providing good care to your patients down the road.
Well, I think we've covered a ton of information on obesity in this deep dive.
We really have. We looked at the definition, causes, complications, treatment options, and even the psychological impact.
And we tied it all back to the MCCQE, highlighting the key points for anyone who's prepping for this exam.
As always, remember that this deep dive was just for informational purposes. It's not a replacement for studying those textbooks or getting advice from qualified healthcare professionals.
Always consult your professors, your textbooks, those healthcare providers. They can give you the guidance you need.
We hope you found this deep dive helpful and maybe even a little bit fun. Keep studying hard, and good luck on your MCCQE.
And best of luck in your future medical career. Thanks for joining us on the deep dive.